Bismillahirrahmanirrahim. Assalamu alaikum. This is Dr. Hooria Aamir. Today we are going to learn about the electrocardiographic interpretation of cardiac muscle and coronary blood flow abnormalities and what is vectorial analysis. Now these things they are quite important when we are learning about ECG. Now what is it we are going to do from the basics? Now, all the serious abnormalities of the heart muscle can be diagnosed by analyzing the contours of the different waves in the different electrocardiographic leads. And you know about the cardiographic leads, what are they? The limb leads, the chest leads, etc. Now, what are the principles of vectorial analysis of electrocardiograms? Now, the use of vectors to represent electrical potentials. Now, what is a vector? A vector is an arrow that points in the direction of the electrical potential generated by the current flow with the arrowhead in the positive direction. The length of the arrow is drawn proportional to the voltage of the potential. And the resultant vector in the heart at any given instant is like this. And this is actually the mean vector through the partially depolarized ventricles. At this instant of the heart excitation, electrical current flows between the depolarized areas inside the heart and non-depolarized areas on the inside and outside of the heart as indicated by the long elliptical arrows. Overall, more current flows downward from the base of ventricles towards the apex than in the upward direction. So you have to keep this thing in mind that the more the current flows downward from the base of the ventricles towards the apex than in the upward direction. This is the key point here. The summated vector of the generated potential at this particular instant is called the instantaneous mean vector and is represented by the long black arrow which is drawn through the center of ventricles in a direction from base towards apex. The summated current is considerable in quantity, the potential is large and the vector is long. Now the direction of a vector is denoted in terms of degrees. When a vector is exactly horizontal and is directed towards the person's left side, the vector is said to extend in the direction of 0 degrees. From this 0 reference point, the scale of vectors rotates clockwise. When the vector extends from above and straight downward, it has a direction of plus 90 degrees. When it extends from the person's left to right, it has a direction of 180 degrees. When it extends straight upward, it has a direction of minus 90 or plus 270 degrees. Now, this is actually how the different directions of a vector are denoted in terms of degrees. And this is from your book, that is One and Only Guide. In a normal heart, the average direction of the vector during spread of depolarization wave through the ventricles, called the mean QRS vector, is about plus 59 degrees. Which is shown by vector A drawn through the center of figure in the plus 59 degree direction. This means that during most of the depolarization wave, the apex of the heart remains positive with respect to the base of the heart. Now X is for each standard bipolar lead and each unipolar limb lead. Each lead is actually a pair of electrodes which is connected to the body on opposite sides of the heart and the direction from negative electrode to positive electrode, and is called the axis of the lead. Lead 1 is recorded from two electrodes which are placed respectively on the two arms, because the electrodes they lie exactly in the horizontal direction, with the positive electrode to left, and the axis of the lead 1 is 0 degrees. In recording lead 2, electrodes are placed on the right arm and left arm. The right arm connects to upper right hand corner, and the left arm leg connects in the lower left hand corner. Therefore, the direction of this lead is about plus 60 degrees. Lead 3 has an axis of about plus 120 degrees. Lead AVR is having plus 210 degrees. Lead AVF is having plus 90 degrees. Lead AVL is having minus 30 degrees. The directions of the axis of all these leads are known as the hexagonal reference system. The polarities of the electrodes are shown by the plus and minus signs in the figure. So we have to learn, if you were asked about what is the hexagonal reference system, so the directions of the axis of all these leads are known as the hexagonal reference system. See, again, the vectorial analysis of potentials recorded in different leads. Now, the previous figure actually shows a partially depolarized heart. The vector A, see, the vector A is representing the instantaneous mean direction of current flow in the ventricles. In this instance, the direction of the vector is plus 55 degrees, and the voltage of potential is represented by the length of vector, which is 2 millivolts. In the diagram below the heart, vector A is shown again, and A line, you see, and A line is drawn to represent the axis of lead 1 in the 0 degree direction. This is how you interpret it. How much of the voltage in vector A will be recorded in lead 1? Now, A line perpendicular to the axis of lead 1 is drawn from tip of vector A to lead 1 axis, and is called projected vector B is drawn along the lead 1 axis. The arrow of this projected vector points towards the positive end of the lead 1 axis, and which means that the record momentarily being recorded in the electrocardiogram of lead 1 is positive. Recorded voltage will be equal to the length of B divided by the length of A times 2 millivolts, or about 1 millivolt. See, the length of vector B multiplied by 2 is equal to, divided by length of vector A is equal to voltage of recorded vector. Again, the vectorial analysis of potentials in the three standard bipolar limb leads. In this example, the instantaneous vector has a direction of 100 degrees and its voltage is again 2 millivolts. To determine the potential actually recorded in lead 1, we draw a perpendicular line from the tip of vector A to lead 1 axis and find projected vector B. Vector B is very short and this time in the negative direction, indicating that at this particular instant the recording in lead 1 will be negative below the 0 line. See the vectorial analysis of potentials in the three standard bipolar limb leads. To determine the potential recorded at this instant in the electrocardiogram for each one of the three standard bipolar limb leads, perpendicular lines are drawn from the tip of vector A to the three lines, representing the axis of the three different standard leads. The projected vector B depicts the potential recorded at that instant in lead 1. Projected vector C depicts the potential in lead 2, and projected vector D depicts the potential in lead 3. In each of these, the record in the electrocardiogram is positive, and that is above the zero line. Why? Because the projected vectors point in the positive directions along the axis of all the leads. The potential in lead 1 is about one half that of actual potential in vector A. In lead 2, vector C, it is almost equal to that in the heart. In lead 3, vector D, it is about one third which is there in the heart. An identical analysis can be used to determine the potentials recorded in augmented limb leads, except the respective axes of augmented leads are used in place of standard bipolar limb lead axis. Now, vectorial analysis of the normal electrocardiogram. The vectors that occur at successive intervals during depolarization of the ventricles. The QRS complex. When the cardiac impulse enters the ventricles through the atrioventricular bundle, the first part of the ventricles to become depolarized is the left endocardial surface of the septum. Then, the depolarization spreads rapidly to involve both endocardial surfaces of the septum. Next, the depolarization spreads along the endocardial surfaces of the remainder of the two ventricles. And finally, it spreads through the ventricular muscle to the outside of the heart. See? So, the instantaneous mean electrical potential of the ventricles is represented by a red vector. Each of these vectors is later analyzed to determine the voltages that will be recorded at each instant in each of three standard electrocardiographic leads. A positive vector in a lead will cause recording in the electrocardiogram above the zero line, whereas a negative vector will cause recording below the zero line. The ventricular muscle has just begun to be depolarized, representing an instant about 0.01 second after the onset of depolarization. At this time, the vector is short because only a small portion of the ventricles, the septum, is depolarized. All electrocardiographic voltages, they are low as recorded to the right of ventricular muscle for each of the leads. The voltage in lead 2 is greater than the voltages in lead 1 and lead 3 because of the heart vector extends mainly in the same direction as the axis of lead 2. Which represents about 0.02 second after onset of depolarization. The heart vector is long because much of the ventricular muscle mass has become depolarized. The voltages in all electrocardiographic leads have increased. So in the figure, after this time, the onset of depolarization, the heart vector is becoming shortened, and the recorded electrocardiographic voltages are lower because the outside of the heart apex is now electronegative, neutralizing much of the positivity on the other epicardial surfaces of the heart. Also, the axis of vector is beginning to shift towards the left side of the chest because the left ventricle is slightly slower to depolarize than the right. Therefore, the ratio of voltage in lead 1 to that in lead 3 is increasing. Um, so again, after this much time, the depolarization, the heart vector points towards the base of left ventricle and is shortened because only a minute portion of ventricular muscle is still polarized positive. Because of the direction of the vector at this time, the voltages recorded in lead 2 and 3 are both negative, and that is below the line, whereas the voltage of lead 1 is still positive. So the vector becomes 0 after onset of depolarization. The entire ventricular muscle is depolarized so that no current flows around the heart and there is no electrical potential generation. The vector becomes 0 and the voltages in all leads become 0. The QRS complexes are completed in the 3 standard bipolar limb leads. Sometimes the QRS complex has a slight negative depression at its beginning in one or more of the leads, the Q wave. Sometimes the QRS complex has a slight negative depression at its beginning in one or more of the leads, depression in the Q wave. When it occurs, it is caused by initial depolarization of the left side of the septum before the right side, which creates a weak vector from left to right for a fraction of a second before the usual base to apex vector occurs. And the figure shows the R wave and the final negative deflection of the S wave. The apex depolarizes, becomes negative. Cardiac vector reverses in direction for a very short time. After the ventricular muscle has become depolarization, about 0.15 second later, repolarization begins and complete at about 0.35 second. Because the septum and the endocardial areas of the ventricular muscle depolarizes first, because the septum and other endocardial areas have a longer period of contraction than most of the external surfaces of the heart. Therefore, the greatest portion of the ventricular muscle mass to repolarize first is the entire outer surface of the ventricles, especially near the apex of the heart. The endocardial areas, conversely, normally repolarize last. This is caused by the higher blood pressure inside the ventricles during contraction greatly reduces coronary blood flow to the endocardium. Thereby, they are slowing the repolarization in the endocardium. Because the outer apical surfaces of the ventricles repolarize before the inner surfaces, the positive end of overall ventricular vector during repolarization is towards the apex of the heart. As a result, the normal T wave in all 3 bipolar limb leads is positive. Over about 0.15 seconds, the period of time required for the whole process to take place, the T wave of electrocardiogram is generated. See how the generation of T wave during repolarization of the ventricles occurs. Again, the depolarization of atria, the P wave. The depolarization of atria begins in the sinus node. Therefore, the point of original electronegativity in the atria is about at the point of entry of the superior vena cava where the sinus node lies, and the direction of initial depolarization is denoted by the vector. The vector remains in the positive direction of the axis of 3 standard bipolar limb leads, lead 1, 2, and 3. The ECGs recorded from the atria during depolarization are also usually positive in all 3 of these leads. Because this direction is generally in the positive directions of the axis of 3. Standard bipolar limb leads 1, 2, and 3. The electrocardiograms recorded from atria during depolarization are also usually positive in all three of these leads. The repolarization of the atria, the atrial T wave. Spread of depolarization through the atrial muscle is much slower than in the ventricles because there is no Purkinje system there. The musculature around the SA node becomes depolarized a long time before the musculature in the distal parts of the atria. Because of this, the area in the atria that becomes repolarization first in the sinus nodal region, the area that had originally become depolarized first. Thus, when repolarization begins, the region around the sinus node becomes positive with respect to the rest of the atria. So the atrial repolarization vector is backward to the vector of depolarization. Therefore, the so-called atrial T wave follows about 0.15 second after the atrial P wave. But this T wave is on the opposite direction of zero reference line from P wave. It is normally negative in the three standard bipolar limb leads. In the normal ECG, the atrial T wave obscured by the large ventricular QRS complex. That's why we don't see it. See? The depolarization, the repolarization. Vectocardiograms can be recorded on an oscilloscope by connecting body surface electrodes from the neck and lower abdomen to the vertical plates of the oscilloscope and connecting the chest surface electrodes from each side of the heart to the horizontal plates. When the vector changes, the spot of light on the oscilloscope follows the course of positive end of the changing vector, thus inscribing the vectocardiogram on the oscilloscope screen. Now we have the mean electrical axis of ventricular QRS and its significance. The mean electrical axis of the normal ventricles is 59 degrees. In many pathological conditions of the heart, the direction of this mean electrical axis changes markedly, sometimes even to opposite poles of the heart. See how to determine the electrical axis from standard lead electrocardiograms. Clinically, the electrical axis of the heart usually is estimated from the standard bipolar limb lead electrocardiograms. One determines the neck potential and polarity of the recordings in leads 1 and 3. If any part of a recording is negative, this negative potential is subtracted from the positive part of the potential to determine the net potential for that lead. Then each net potential for lead 1 and 3 is plotted on the axis of the respective leads with the base of potential at the point of intersection of the axis. Then each net potential for lead 1 and 3 is plotted on the axis of respective leads with the base of the potential at the point of intersection of the axis. If the net potential of lead 1 and 3 is positive, it is plotted in a positive direction along the line depicting lead 1. Conversely, if this potential is negative, it is plotted in a negative direction, So, one draws perpendicular lines, the dashed lines in the figure I'm going to show, from the apices of lead 1 and lead 3 respectively. The point of intersection of these two perpendicular lines is represented the vectorial analysis, the apex of mean QRS vector in the ventricles and the point of intersection of the lead 1 and lead 3 axis represents the negative end of the mean vector. See? The vectorial analysis of left axis deviation seen in hypertrophy of the left ventricle. Left axis deviation with mean electrical axis pointing in 15-degree direction is seen in systemic hypertension, aortic valvular stenosis, aortic valvular regurgitation, congenital heart conditions. Then we have conditions like in which the vectorial analysis is of right axis deviation, intense right axis deviation to an electrical axis of 170 degrees, hypertrophy of the right ventricle as a result of congenital pulmonary valve stenosis, congenital heart conditions that cause hypertrophy of the right ventricle like tetralogy of Fallot or Fallot's tetralogy, and interventricular septal defect. See? So, this is all about how we do the interpretation by seeing the axis deviation. So, I hope all of you will read it and try to grip it. So stay blessed and keep your studies updated, and Allah Hafiz.